Hi, my name's Leanne Atkin. I'm a vascular nurse consultant from Mid York's NHS Trust, and this short video is in relation to leg ulcer assessment. Ensuring you have the accurate diagnosis of the underlying cause for a leg ulcer is an essential component in moving your patient forward. We really need to think about what has caused or what is delaying that wound healing in that patient. So, when we're thinking about diagnosis, how do you go about diagnosing a leg ulcer? So actually, you need to use a systematic method, and we really need to be thinking about what is that underlying factors? What are their risk factors from a venous and an arterial point of view? What type of investigations do we need to be doing from a wound point of view? How do we interpret that ABPI, which is often the key to the door for compression therapy? How do you use all that information to make that accurate diagnosis of whether you believe this is a venous ulcer, a mixed disease ulcer, or an arterial ulcer? And what investigations can you use to help confirm your differential diagnosis? And I just want to really point it out that an ankle brachial pressure index, an ABPI, does not confirm the diagnosis of a leg ulcer. It doesn't tell you whether this is a venous leg ulcer or not. The ABPI is simply there as a safety measure of is that patient suitable for full strength strong compression. But actually the diagnosis comes back to your clinical skills. Hence why we're doing this video today. So I want you to think when you are seeing a patient with a lower limb wound, what has caused that breakdown in their skin? Because there's many reasons why that breakdown occurs. And we really need to be labelling our patients in terms of that accurate diagnosis. And this is essential as the diagnosis is linked to evidence-based treatment pathways. So if you have a patient that's got venous ulceration, they need strong compression. If you've got a patient with an arterial ulcer, they need referral to vascular services and revascularisation. If you have a patient that's got significant edema or lymphedema, we need targeted strategies to be able to reduce and improve that lymphatic return. So we also need to think about traumatic wounds. Even if they are traumatic, we need to think and assess that patient for susceptibility of venous disease or arterial disease, thinking about their ability to heal and how do we optimise that. We also need to be thinking of the other causes of wounds, and there's many of them out there. Is this directly related to pressure? Is it in terms of a malignancy? Is this because of infection? Could it be their autoimmune disorders that's underlying that's causing these wounds? But actually the accurate diagnosis is key, and I urge you all to become experts in this. And another reason why the diagnosis is really required is it helps you to think about whether you are able to heal this patient or not. If you've got a patient with venous leg ulceration, we should be questioning healing, and we should be questioning why hasn't this patient healed at every 4-week review. But actually, if you've got a patient with underlying arterial disease, then actually there's very little you can do as a nurse to help that wound to heal. It's about managing that patient's symptoms, working alongside the vascular service to try to quest healing. So your accurate diagnosis is needed to actually think about what management strategies you need, but also to think about that patient's ability to heal and how quick that patient should be healed. I urge you all to really stop thinking about managing wounds. We often talk about in the NHS about managing a wound well. I think we shouldn't be managing wounds. I think we should question healing with these patients. And that's really where I want you to be focusing on. And when we think about a lower limb patient with a wound, we really need to be thinking about that holistic assessment. And that holistic assessment comes in 3 forms to me. It's about the assessment of the patient, the limb, and then the wound. And many of us can actually start to jump straight to assessing a wound, and it really is bad practice when it comes to leg ulceration. So we need to be thinking about those patient factors. Rather than jumping straight in and thinking of what dressing do I need on that wound, actually we should be stepping back and really thinking about how do we assess that patient. because there are signs from that patient, there are clues from that patient in terms of underlying disease. And this part of the session is really going to concentrate on the two major components of lower leg ulceration. So we're trying to tease out venous hypertension versus arterial insufficiency. So if we think about that from a patient point of view, you're more likely to have venous insufficiency if you've got visible varicose veins, if you've got a previous DVT, if there's any evidence of edema or lymphedema on the lower leg, if that patient's had any form of previous venous surgery, the varicose vein stripped, or venous ablation, they're more likely to have a venous hypertension and therefore a venous leg ulcer. Also, patients with higher BMIs are more likely to have a venous disease. In contrast, you need to be thinking about whether this could be arterial if your patients had any previous heart attacks or strokes, because heart attacks and strokes are atherosclerotic disease, so there is hardening and narrowing of the arteries that leads to a heart attack or a stroke. So you get narrowing of arteries around the myocardium that leads to angina and heart attacks, or around the carotid arteries that leads to transischemic attacks or strokes. It's the same disease that causes peripheral arterial disease, so arterial ulcers. It's the same hardening and narrowing of the arteries. And we are all one system, so if you've got deposits around the heart or around the brain, you're more likely to have deposits on your lower leg. So that heart attack or stroke history really needs to be raising your hackles in terms of, could this be an arterial ulcer? If patients are a smoker, they're more likely to have deposits within the arteries. Same as if they're a diabetic, consider carefully, could there be any evidence of underlying arterial disease? Hypertension is also a red flag. It's a red flag because it's a clear risk factor developing arterial disease, and many of your patients out there will have hypertension. So again, just think about that. Don't think about that in terms of venous hypertension, it's a totally separate thing, but think about whether you've got hypertension, and that's actually more likely to have arterial disease. Same as if a patient's got any history of any form of vascular surgery before, any form of angioplasty, stenting of the lower legs, bypass surgery, they're much more likely that this lesion that you are now assessing will have an element of underlying arterial disease. And it's also about asking that patient specific questions, trying to tease out if they've got any early symptoms of arterial disease, such as intermittent claudication. So that's pain that happens when a patient walks. It's really easy to diagnose. A patient often reports they get significant crampy type pain in the large muscles of their lower leg, predominantly on their calf, but can happen in their thigh or their buttock. But a patient will be able to say to you, I can walk for 50 yards, then all of a sudden I get this severe crampy type pain in the back of my leg. When I stop for a minute or two, the pain disappears, and I start walking again, the pain comes back. That's classic intermittent claudication. If they're saying they get pain when they're sat down, when they're in bed on a night time, as soon as they set off walking, or that pain doesn't relieve when they've stopped, it's very unlikely to be intermittent claudication. But we need to be thinking about the patient as a whole, looking at their risk factors for both venous disease and arterial disease. Once we've assessed the patient, we need to also be having some consideration of, is there any risk factors that you've just teased out that's actually going to make this patient harder to heal? Even if it's not related to the underlying cause, things like obesity can make a wound harder to heal, both whether it's venous or arterial. If a patient's getting on specific medications, it can impact a patient's ability to heal. If they've got any underlying autoimmune disorders, that can make a patient more difficult to heal. And there's a list here of all of the factors that actually impact and make a wound more harder to heal. And it's really important that you're aware of these to try to control as many as possible, or at least highlight that this patient may be more challenging to get that final wound to heal. So once you've assessed the patient, it's then time to focus on the limb. And again, there are signs and symptoms of classic venous disease compared to arterial disease. So you can get edema. You can get edema that is soft Or you can get edema where you've got fibrotic changes and lymphatic changes such as lipodermatosclerosis. With venous disease, you can also often get venous eczema. So you get that golden crustation, especially around the medial gaiter. You can get the classic hemosiderin staining as seen, where you get the hemoglobin deposits on that surrounding tissue, and that's a classic sign of venous disease. I appreciate that some of these can be more challenging on non-white skin, but as you can clearly see here, you can still see hemosiderin staining in the darkest of pigmented skin. So every patient needs to be assessed in the same frame. With a venous leg ulcer, they too more commonly occur on the medial gaiter. So the gaiter region around the leg and on the inside of the leg. And that's where they commonly occur if it's venous in origin. You can often get some surrounding inflammation that goes wider than the wound margin, and sometimes that's actually circumferential all the way round the gaiter as seen within this image. And that's a clear indication that you've got underlying venous disease. You've got venous inflammation that's causing this surrounding erythema. So let's now compare that to what the signs and symptoms are of the leg of an arterial patient. Well, the skin tends to look more shiny because the nutrients and the oxygenation of that final layer of the skin has changed. You can get a foot that looks red. We call this a sunset foot because, as you can see, it becomes bright red. But it's really interesting with a sunset foot that many of you may think that that looks like infection, such as cellulitis. But if you raise that leg up to the level of a hip, you can see that the colour starts to drain away and that foot goes back white again. And the reason why that foot becomes sunset is that you've got maximum vasodilation, so you've got flushing of the foot, just like when you get flushing of your face. And that's what we class as a positive Burgess sign. So you've got dependent ruber that disappears on elevation. And that's a clear indication that there is a problem with the arterial supply. The leg itself can often be hairless and you often get absent hairs on your toes. You get an increased thickening of the nail bed because of the change of the nutrients and the oxygenation to the tissue. But one of the major things with the arterial patient is that these wounds will be significantly painful. When patients got venous ulcers, some of them may be painful, some of them may not be painful. And I can tell you in my career there doesn't seem to be any correlation with the size of the wound from a venous point of view to the amount of pain. I've seen patients with small venous leg ulcers in agony and patients with massive circumferential venous leg ulcers with no pain. But with arterial ulcers, the patients are always in absolute agony. It comes on relatively quickly and it is an unforgiving pain. The only caveat to that is if patients have got underlying diabetic neuropathy, where they may have absence of that pain. And often with a patient with arterial insufficiency, you will find that wound actually on the foot, especially below the level of the malleolus. So it'll often be on the peripheries of the toes or on the dorsum of the foot. So there's clues for you in terms of signs and symptoms when you're assessing the limb of whether this is arterial or venous. And then finally, and it's only now when you can start to assess the wound itself. And when I talk about wound assessment, actually it's about determining whether this is a venous ulcer or an arterial ulcer. So the classic indication of a venous leg ulcer is one like this. One where the wound looks relatively flat. You've got irregular shape around it. They're often highly exuding because of the underlying venous hypertension. You often find that the wounds are either granulating or sloughy. Finding necrosis in a venous leg ulcer should be a red flag because it can be relatively rare. It can happen, but again, it should be a little bit of a red flag. And with venous leg ulcers, they tend to develop over a matter of weeks. So patients often report that they initially had an episode of itching or erythema and inflammation. That slowly develops into an area of ulceration over a matter of weeks. And let's now compare that to what we see with a patient with arterial wounds. They often are round, circular, relatively punched out, especially if they're on the limb. But like I said, most arterial ulcers actually exist on the foot. With an arterial wound, they're often dry. You don't tend to find you get granulation tissue at the base of these. They're either sloughy or necrotic, eschar, black necrotic tissue. And with an arterial wound, they tend to develop very quickly. So 2 weeks ago, the skin was absolutely fine, and then all of a sudden, you've got this area of ulceration. Hopefully, by understanding the differentials between venous and arterial assessment, thinking about the patient, the limb and the wound, helps you to inform and make the accurate differential diagnosis. And the reason why we need this is that limb ulceration is not just a simple wound. We need to think about what's happening behind that wound in the structures of the skin, in the arteries and the veins. Because actually we need to be thinking about the lower limb wound is either a weed in terms of venous hypertension or a blockage in terms of arterial insufficiency. And we need to be targeting the underlying cause to help these patients to heal quicker. So I hope you found that session interesting. I urge you all not to jump straight to the wound. Think about having that holistic assessment of a patient when you're trying to gain that accurate diagnosis. Looking at the patient, then looking at the limb, and then looking at the wound in terms of clues for underlying pathophysiology. Thank you very much.